Okay. Hi, I'm Dr. Orvis, Sue Orvis. I'm at Family Vision Center in Cedarburg. I am an optometrist, a medically certified optometrist. And we're going to go over a lecture titled Clinical Ophthalmology to help you learn how to diagnose and treat common eye conditions that you may see in a regular general practice. The key to being a good diagnostician in just about any branch of the medical specialties is just listening. Just listening to the patient, you can gain a lot of information. And I find that if you are a good listener, you really can formulate a really good idea of what the diagnosis is going to be before you even look at the patient themselves. And obviously with the history, with listening, we want to write down, if somebody comes in with a complaint, we want to write down or make notation of the location of the complaint. Where is it? The quality, the severity, how much pain, how much mucus, etc., the duration, how long have they had it, timing, does it get worse in the morning, is it better in the evening, context, it kind of talks about the whole picture. Is it related to, gee, you know, I get a headache and then this happens, modifying factors, if you put a hot compress on it, does it make it feel better, if you put a cool compress on it, does it feel better? And then your associated signs and symptoms, what other systems could be related. You know, certain eye conditions can be related to systemic problems. If your blood sugar is high, for instance, your vision gets blurry. So there definitely is a relationship between systemic conditions and certain symptoms of the eye. The most important question that I find when I see somebody coming in with a complaint of their eye is pain. The nice thing with the eye is the way that it is built, the way that it is constructed, there are pain nerve endings in certain parts of the eye and not in others. If a person comes in with a painful eye, you can pretty much figure out or kind of rule it to, it's probably the cornea, which is the front surface of the eye that covers the iris, or it's the eyelid. If there's not a lot of pain involved, it's probably the conjunctiva, which is the tissue that covers the white of the eye. And when people come in and they talk about, gee, my eye hurts, it's real important that you ask them, is it your eye or is it the lid? Because most people just kind of describe pain of the eye, anything that comes in the area of the eye. If you ask more specifically, is it your eye itself or is it your lid? That's when the patient will usually start saying, oh no, it's not my eye, it's actually my eyelid. So it does definitely help you differentiate where the problem is. Also, how badly does it hurt? People can describe their eye pain as, you know, it's sore, but it's tolerable. There's eye pain when you have an injury of the cornea. That eye pain can actually induce people to vomit. It is so severe. So depending on the severity of the pain, you can also sort of rule out where or where not is the problem. Pain nerve endings of the eye are most concentrated in the cornea, the front surface of the eye. So if somebody comes in with intense pain, chances are they have something wrong with their cornea. There are no pain nerve endings inside the eye. So if there is an injury in the eye, a retinal detachment, let's say, there will be absolutely no pain whatsoever. When people go in to have cataract surgery, because they are working inside the eye, there's actually no pain medication given after cataract surgery because there is no pain inside the eye. You also have pain nerve endings in the lid and the skin of the lid, just like your skin elsewhere in the body. There are very few pain nerve endings on the conjunctiva, the tissue that covers the white of the eye. So depending on how people are describing their pain, the intensity and whatnot, this kind of helps you judge, does it seem severe enough that it could be the cornea? Is it not real severe? It could be then the conjunctiva itself. Is there no pain whatsoever? Maybe it's something going on with the inside of the eye. So I'm going to first go over the group of conditions that we call conjunctivitis. This is probably the most common type of eye condition that you're going to see in a general practice. Most people think of conjunctivitis as quote-unquote pink eye. Pink eye is considered a bacterial conjunctivitis, but there is also allergic conjunctivitis as well as viral conjunctivitis. Bacterial conjunctivitis will by far probably be the most common one that you will encounter. A bacterial conjunctivitis is actually a bacterial infection of the conjunctiva itself. Now, the conjunctiva is the tissue that covers the white of the eye as well as the undersides of the lid. The conjunctiva is not part of the cornea. So if you remember, the conjunctiva does not have a lot of pain nerve endings. So people who have bacterial conjunctivitis usually will not complain about pain. They might say their eye feels a little bit gritty. They might say it's a little bit sore. They might even complain that it itches a little bit, because when the conjunctiva swells, any tissue that swells becomes a little bit itchy, but certainly itching is not going to be the hallmark symptom. The hallmark symptom of bacterial conjunctivitis is they have to have mucus. If they do not complain about their eyes are pasted shut in the morning, they do not have a bacterial conjunctivitis, they have something else. So they must have that mucus component. Contact lens wearers, you have to be especially careful with them because they definitely work around the eye with their hands a lot more. They're touching their eyes a lot more. Any type of injury to the eye that's caused by the contact lens, if you get bacteria in it, it can cause a more severe reaction. So the way that we treat a bacterial conjunctivitis is with a broad spectrum topical antibiotic. So here's a couple slides of what bacterial conjunctivitis usually looks like. Because it is the tissue of the white of the eye and underneath the lid, you'll usually see with looking at these patients, much more redness as we get towards the bottom of the eye. The cornea covers the iris up here. This part usually will look pretty normal, but as we go downwards, you're going to see more and more redness. You might see this looks kind of glossy because it's inflamed. This little speck right here is actually a spot of mucus. So we definitely want to look for the signs of, is there mucus floating around in the eye? And sometimes the mucus you can see with the naked eye, sometimes you can't. The other thing I want to mention is bacterial conjunctivitis is pretty rare in adults. We wash our hands. We know not to put dirty fingers in our eyes. So for an adult to have a bacterial conjunctivitis, it's actually pretty unusual unless they are working in a setting where they are exposed to a lot of children. So someone who is in a daycare type of profession, a teacher or whatnot. An average normal adult usually is not going to get bacterial conjunctivitis. Maybe if they have really, really poor hygiene habits and they wear contact lenses. But usually if you have an adult coming in, that's one of the first things that I don't think of is bacterial conjunctivitis, or it's one of the first things that I kind of rule out. As far as medications for bacterial conjunctivitis, one of my favorites is a medication called Polytrim. Polytrim is an old-fashioned, it's trimethoprim, sulfa, and bacitracin mixed together. Even if someone has a sulfa allergy, they're normally not allergic to Polytrim. It is great on a very wide variety of bacterias. Especially kids are prone to a bacteria called Haemophilus, and Polytrim is one of the few drops that actually can target Haemophilus. Moxiza, Zymaxid, Siloxane, these are all versions of cephalosporins. Very strong drops, very efficient. Problems with some of these drops is they're incredibly expensive.
I just have a question. You know, how does erythromycin ophthalmic ointment work for this? Is that something that's recommended?
So the question is, how does erythromycin ointment work for this? Erythromycin has a pretty small target as far as the bacteria that would affect the eye. The other thing is, let's say in an adult or even in a child, if you have ever tried to use ointment throughout the day, it is messy, it blurs your vision. Your patient will probably not like you if you prescribe them an ointment. I generally never prescribe an ointment unless it's bedtime, just because of the blurring of the vision. If you're an adult and you're using ointment, if you're a woman, your makeup is all over your face because of the greasiness of it. It's just not really user-friendly. So I usually always try to, especially with adults, stay away from ointments Unless I want some type of nighttime coverage,
Okay.
then I would prescribe it for nighttime use only.
And as far as women go, you know, with makeup, with bacterial conjunctivitis, how long should they be without makeup? I mean, you know.
Usually what I'll tell, the question was, how long should a woman be without makeup who has bacterial conjunctivitis? So normally once you are on medication for 24 hours, you are not contagious anymore. I will usually tell women to wait at least 48 hours before starting makeup. But the makeup can harbor some of the bacteria, and usually it's going to be a liquid makeup that harbors bacteria. So I will usually tell people to replace their mascara or any makeup that they're using that's liquid. So mascara, eyeliner are the most common of the two. Eyeshadows and things like that that are not liquid usually are not going to harbor bacteria. So if they're using an eyeliner pencil, I think that is safe. If they're using, regular eyeshadows and things like that, I will tell them that they normally do not need to throw that stuff away.
Okay.
Yeah.
Thanks.
So let's say you have a patient that has a bacterial conjunctivitis and it just won't go away. You've tried an antibiotic drop, it didn't seem to work. You put them on another antibiotic drop thinking, well, maybe that one didn't have full coverage, maybe they're resistant to it. And let's say that patient definitely has lots of mucus, just all the harbor signs of a bacterial conjunctivitis. What do you do? So yes, you can try another antibiotic. You can, obviously relook at the eye. You can refer them to a specialist. Ask them if they were using the drop correctly. You would be amazed that even though you tell the patient to use the drop 4 times a day for 7 days, maybe they only use it twice a day for 2 days, their eye felt better, they stopped using it, and the infection came right back. So it's always good to double check if somebody calls you back saying the drop isn't working, how were you really using it, and were they really using it as instructed? So if you are quite positive that, no, this person does have a bacterial infection, it just does not seem to be going away, you've tried a couple different antibiotics, you are really quite sure that, yeah, I do believe that they were following directions as instructed, one thing you need to think about is chlamydia. We also call chlamydia inclusion conjunctivitis. Chlamydia, people who have chlamydia infection of the eye will also have a genital infection of chlamydia as well. The hallmark of chlamydia is just lots and lots of mucus. I mean, these people's eyes are just like little mucus factories. They just pump out mucus. So this is a picture of a person with chlamydial conjunctivitis, and I'm not quite sure how well the slide shows up, but you'll see like these little circular, they're follicles, and they're just filled with mucus. And when you see these people, I mean, they just have mucus dripping out of their eyes. You can see that the underside of the lid here is very swollen. It's very irritated. They will usually not complain of pain or anything like that, but they just have a goobery, mucusy eye that's, probably a little bit puffy, a little bit teary just because of the irritation. So the nice thing with chlamydia, if there is a nice thing of chlamydia, is that it is very susceptible to Zithromax. So what we do is when we see somebody with chlamydia, 1,000 milligrams of Zithromax is chlamydicidal. It'll actually kill it in one dose. So what we normally do is we prescribe a tri-pack of Zithromax, and then you get 3 pills of 500 milligrams each. We'll tell them to take 2 pills together, so they have that 1,000 milligrams together. Technically, that's all they need to take, but what I usually do, since there's 3 of them, is I will tell them, you take 2 pills together the first night, first thing the next morning I want you to take that 3rd and last pill, just as kind of an extra insurance policy.
Do you ever culture?
Do I ever culture? Usually not, just because it's pretty obvious when you see a chlamydia what it is, especially if you see a lot of chlamydia, which thankfully we do not. The other reason why I don't culture is zithromycin is very tolerable, that if you give somebody, this 1,000 milligrams of zithromycin, you take it and whatnot, if it doesn't work, then I would maybe consider, okay, this is something that I'm not quite sure what it is, then perhaps a culturing then. But it responds so well, and people, take zithromycin so well that it's just worth, let's just try it and see if it gets rid of it.
Good.
All right, allergic conjunctivitis next to bacterial conjunctivitis is probably one of the next more common eye conditions that you'll see for people coming in with, my eyes bothering me. And allergic conjunctivitis, just like any type of body allergic reaction, people usually come in, their eyes are itchy, they're teary, their noses are runny. They normally know, most people, I have hay fever, it's usually a seasonal type thing. And the symptoms can vary from person to person quite a bit. Some people can have severe itching. Other people, it's more, my eyes just kind of look red and they're glossy. They don't really get the itchiness. So it can be a little bit different in each and every person. Usually with allergic conjunctivitis, you can have some mucus. With bacterial conjunctivitis, the mucus is usually just kind of thick. It can be kind of yellowy in color. With an allergic conjunctivitis, if you have mucus, it's going to be more white and ropey. So the patients will kind of complain, I'm pulling these mucus strands out of my eyes and they'll come out looking like little strings. And what happens is when your eye is allergic to something, when you're having an allergic reaction, your eye tends to produce extra protein, and that's what these strings are made up, is protein. Usually when you have a person coming in with an allergic conjunctivitis, they usually just have these all over pink looking eyes. They're not necessarily a bacterial conjunctivitis. It's real red towards the bottom of the eye. You don't have this focal redness. The whole entire eye is just overall kind of a pink in color. Their eyes usually look like they're watery. This picture, lower picture down here, is if you invert the eyelid, turn the eyelid inside out, people with allergies normally will have blisters on the undersides of their eyelids. And you can simply take a Q-tip to invert the eyelid and take a quick peek underneath there, and you'll usually see a bunch of little bumps under there. So what do we do for an allergic conjunctivitis? Sort of like anybody who has an allergic reaction, one, I'll ask them, do you take any type of oral allergy medication? Are you on a Claritin? Are you on a Zyrtec or Allegra or whatnot? That will usually help to some degree. There's two schools of people, however, with allergic conjunctivitis. Those who are on an oral medication and it actually helps the eye condition. There are some people that go on the oral medication and it does nothing for their eyes. So then for those people, we do have to supplement and give them an eye drop to help with the symptoms. Now, the downfall with allergy eye drops, there's so many over-the-counter allergy medications that a lot of insurance companies do not like to pay for prescription allergy drops. So sometimes it is a fight to get an insurance company to pay for them. There's a lot of pre-authorizations and whatnot that have to go on. My two favorite topical prescription allergy eye drops are Pataday and Lasticap. They're kind of like Pataday a little bit better. They are once-a-day drops. Like all allergy medication, you do have to tell your patients you need to take this drop every single day, whether your allergies bother you that day or not. An allergy response is a chain reaction of a cascade of events, and if that chain reaction is allowed to start, they're going to have an allergic reaction at some point in time. So you need to stop that chain of events and keep it stopped. So after about 3 or 4 days of being on an allergy drop, the eye will start feeling better. It is so important that those people stay on the allergy drop even once their eyes feel better. If it is a true seasonal allergy, I will tell people you take this drop every single day until the first hard frost. Once that first hard frost comes along, try stopping it and see if your allergic reaction comes back. If it does, they may need to be on that drop longer. Allergy drops are very safe to be on year-round, and I have some patients that do have to be on them year-round every single day. Zaditor is an over-the-counter allergy drop that used to be prescription. I find that it is one of the best over-the-counter allergy type drops. Zaditor, you take that twice a day. Other over-the-counter allergy drops, you might have to take up to 3 to 4 times a day. It's one reason why I don't love over-the-counter drops, because most people will not consistently take them. 3 to 4 times a day. I mean, just in your lifestyle, you forget about it and whatnot, and so you tend not to have as good of allergy control. A little clinical pearl is, especially if a patient has itchy eyes, putting an allergy drop in the refrigerator, putting an artificial teardrop in the refrigerator, putting a cold drop in the eye instantly stops the itching. Itching, does not like cold. So anytime you have somebody that's experiencing a lot of itching problems, you really could, if they don't have time to run to Walgreens and get an allergy drop, let's say, put a regular drop of bottle of even their contact lens solution, a regular artificial teardrop bottle, put that in the refrigerator, put a drop in their eye once it gets nice and cold, and it will instantly take care of itching. So, little pearl that I tell all my patients, put your allergy drops in the refrigerator, put a little artificial teardrop in the refrigerator, and if you just get severe itching, put a drop in each eye, you'll be amazed at how quickly it'll stop the itch. All right. Next, we're going to go over viral conjunctivitis. These are not quite as common, thankfully. Viral conjunctivitis can get kind of messy in some patients. There's lots of different viruses that can cause problems with the eye. Probably the most common one that we see is something called epidemic keratoconjunctivitis, EKC. It's very, very extremely contagious, and I've seen school districts be shut down because of this virus. Viral conjunctivitis can have some overlapping symptoms with bacterial conjunctivitis, but a couple things that it has that's different. In a viral conjunctivitis, these people's main complaint is usually pain. They're usually more uncomfortable. So with the bacterial conjunctivitis, they might say, yeah, my eyes feel a little gritty, they're a little uncomfortable. People with viral conjunctivitis, usually their eyes hurt. I mean, you can just, by listening to them explain their pain or describe their pain, usually you can get a pretty good picture of this is a little bit more than achy. This is usually something that is not comfortable at all. They're usually light sensitive. They may say, they'll come in, and even when I have my exam room lights on, they might even say, can you turn the lights down? My eyes hurt with the lights. They can complain, and I usually find one of their top complaints is that their eyes are really teary. They'll usually come in with a tissue in their hand, and they're constantly dabbing their tears. And their tears are usually not like regular watery teardrops. They're usually, I'll ask them, do they seem real syrupy? They seem to them very thick. And usually they'll say, yeah, they're just really thick tears, and it just doesn't stop. Their eyes are like little faucets. It's just nonstop. They can also complain of mucus. However, this is not a bacterial infection, and the reason why they're getting mucus, I'll usually ask them, do you normally just have the mucus in the morning, or is it throughout the whole day? And usually they'll say, you know what? I'm real mucusy in the morning, but once I clean up my eyes, I'm not getting as much mucus during the day. And the reason why that is the tears are what's holding the virus. And when these people sleep at night, their eyes are tearing. And what happens is the water component of the tears is evaporating out, but the viral component of the tears is not evaporating. And so when the water evaporates out, their tears turn into like this thick, almost mucus-like consistency. So they'll complain about mucus usually just in the morning, and it's not the true bacterial mucus that we think of, it's because of their tears, the water component has evaporated out. During the day, because their eyes are open and they're sopping up their tears, they normally will not get that crustiness throughout the day. They'll just have it in the morning with the stagnant tears. So usually the presentation of viral conjunctivitis is their eyes look wet. I mean, just when you look at them, it just looks like their eyes are very, very glassy. They're usually, as I said before, very light sensitive, and the reason why that is viral conjunctivitis usually affects the cornea. So whereas a bacterial conjunctivitis usually is going to affect the conjunctiva, the undersides of the lids, the tissue over the white of the eye, viral conjunctivitis usually also attacks the cornea as well as those other structures. And if you remember, there's more nerve endings in the cornea than anywhere else in the eye, And that's where the pain comes in, that's where the light sensitivity comes in. So with a viral conjunctivitis, if you can rule out, and when I talk about viral conjunctivitis, the exception that I'm making with this is it cannot be a herpetic infection, it cannot be herpes, and we'll cover herpes in a minute. So usually with viral conjunctivitis, with any virus, we can't cure a virus. A virus has to run its course. And unfortunately, most viruses, to run its course, it is usually a 14 to 21 day ordeal. These people are very uncomfortable. So what I do with them is I prescribe them a steroid. And what the steroid does is it calms their cornea down. It gets rid of some of the inflammation. It makes the eye look better. It makes the eye feel better. But you have to educate these patients that even if the eye looks and feels better, they still have the virus. And it is going to be a good couple weeks before they are considered viral free. So they need to be very, very careful with washing their hands. The tears that's coming out of their eyes is what harbors the virus. They wipe their eye, they touch a doorknob, somebody else touches the doorknob, touches their eye later in the day, they've just spread it to somebody else. So this is very, very easily contagious. It's very easily spread. So these people have to be very, very careful. Lately, finally, this is newly FDA approved. We have been using this in the office for about the last 10 years or so. It was an off-label use of betadine. Betadine actually can kill viruses. So betadine is wonderful if you have somebody coming in. I recently had, it was a husband and wife. The wife had it so much worse than the husband did. They were in so much pain. Even when I put them on a steroid, it really didn't cut their pain. And you know, with a virus, it's hard to tell an adult person. You just have to let it run its course. So what you can do is you can get 5% betadine. You do have to numb the person's eye. So just a topical proparacaine drop that most, offices will have. And you put a couple drops of proparacaine in each eye, wait about 3 minutes. And then what you want to do is instill a drop of betadine in each eye. And then about 2-3 minutes later, you want to do a second drop. And that will shorten the life of the virus greatly, probably by about 70%. So you do have to let the person know betadine is very irritating to the eye. Their eye, when the numbing drop wears off, is not going to feel any better. If anything, they might complain, oh my God, it's even more scratchy than it was before. It may be that way for about 2 hours, 2 to 3 hours afterwards. So I tell people after I do this, you need to go home, you need to lay down, take a couple Tylenol, try and take a little nap. By the time they wake up from the nap, usually their eye is feeling better by then. Betadine is toxic to the cornea, so basically what it's doing is it's kind of giving them a keratitis, almost like a very superficial abrasion across the cornea. But because of how greatly it shortens the viral lifespan, most patients are very happy to put up with a couple hours of maybe a little bit more discomfort to bring a faster end to the whole ordeal. If you have a red eye again that you think, gee, this red eye is not going away. I've treated it with antibiotics. There's not a lot of mucus, but this patient keeps complaining that they have this chronic red eye. I'm not quite sure what it is. They're not really complaining of pain. There's not a lot of mucus. They're not complaining about itching, but they definitely have a red eye. What can it be? And usually this will be unilateral. Every now and then it can be bilateral. But if you look at this person's eye, you'll see this little lesion on the lid. And then you'll see this little lesion on the skin right here. And actually underneath the lesion, there's another one. This is a molluscum contagiosum, which is a viral infection. And you can get this anywhere on the body. It is actually a skin virus. A lot of people describe these as swimmer's warts. And you can have them on the eye margin, the eyelid margin. And when it comes on the eyelid margin, because the virus is secreting toxins, those toxins are getting into the eye, and that's what's causing the chronic red eye. So normally, as I mentioned before, there is no symptom as far as, hey, it hurts, it's itchy, there's mucus. You're not going to have any of that. You're going to have a person just coming in with, what's up with my eye? So look at the eye, and if you see one of these on the eyelid margin, if you, in this one over here, if you can see, there's actually a little white core to it. What I do with these is I put some topical numbing cream on this, and I take a sterile needle. If you dig out that little white core, it'll go away. You don't need any drops, you don't need any ointment, you don't need any type of treatment. You just need to get rid of that viral core. And once that core is gone, that lesion will go away. Now, if you see lesions throughout the rest of the body, you might then want to say, you know what, maybe a little trip to the dermatologist would not be a bad idea, so they can treat these little lesions. I had a patient, she was actually a young girl. The only lesion she had was the one on her eyelid. She didn't have it anywhere else. And so once we got rid of the one on her eyelid, her chronic red eye went away. And the mom was very thankful because they had gone through 3 rounds of antibiotics with the pediatrician, and she was a little bit unhappy because of all the money she spent in the expense of the antibiotics, where it was really didn't need any treatment whatsoever besides getting rid of that little vesicle. Herpes is another common virus that you may come across. We do not like to see herpes infections in the eye because herpes has a tendency to scar the eye. So anytime you have a person coming in who is complaining about pain of the eye, who's complaining that, usually with herpes, their number one complaint is not so much going to be pain, it's going to be that their eye is teary, because the herpes infection affects the cornea. Anything that affects the cornea is going to produce tears. They will also complain that the eye is light sensitive. So with a herpes infection, as I mentioned pain before, pain is normally way down on the bottom of their list of complaints. And even though herpes is attacking the cornea, and you would think anything that attacks the cornea would cause a lot of pain, herpes doesn't, because herpes attacks the pain nerve endings and kills them. So with herpes, pain is usually their least in their lineup of what is bothering you the most. They'll usually say light sensitivity is bothering them the most, followed by tearing. Pain will be the least, because the herpes infection, the simplex, is killing the pain nerve endings that are in the cornea. If you have a person who comes in who've had multiple episodes of herpes in the eye, you could actually take a cotton Q-tip, wisp out the cotton, and you could actually rub that cotton against their eye and they won't even blink. They can't feel it at all because the nerve endings in their cornea have been killed. And that's actually a bad thing, because we have all those nerve endings in our eyes to protect our eyes. You know, our eyes do not have a lot of good self-defense besides us closing our eye and shielding our eyes. And so when you lose that instinct of pain, or there's a presence of something near my eye, you're going to be much more prone to developing other infections and injuries of the eye. People who come in with these herpes infections, they might have other herpes patches on their face, little crusted pustules on the face. They might not. They might have a completely clear face. They might not have a cold sore going on. If I suspect someone of having herpes, one thing I'll ask them is, have you recently had a cold sore or any kind of a herpes infection? Because they may have been touching the cold sore and then possibly touching their eye, because it's the fluid in the cold sore that harbors the virus. With herpes infections in the eye, it's usually almost unilateral. It almost is never, ever bilateral, because herpes, just like with zoster, tends to follow certain dermatomes, and so it's very unusual to affect both sides at the same time. Not that it can't happen, but it's probably 1% of the time. So there's herpes simplex, which is the same as cold sores, and we're talking herpes simplex number 1. Herpes number 2 is the genital disease. People who have herpes in the eye, it is not the same as the genital herpes. So if you are telling somebody that they have herpes simplex number 1, I usually go out of my way to inform them this is not the same as genital herpes, because people start to get panicked and they don't know the difference, and they, start looking at, their partner if they're in the room or whatnot. So I just like to inform them this has absolutely nothing to do with genital herpes. This is something that's completely different, just to relieve them of any angst that they might get. Herpes zoster is, also obviously a herpes infection, but this is shingles. So this is related to the shingles that people get on their skin, caused by the virus that causes chickenpox that has gone dormant in their body. And then for whatever reason, the virus becomes active again in certain nerves. It could be stress that activates them. It could be a decrease in their immune system. We're not quite sure why some people get zoster or shingles and some people do not. It's very common that herpes attacks the trigeminal nerve. The trigeminal nerve has 3 divisions across the face. So you have below the jaw, above the jaw, and underneath the eye. Herpes zoster is, again, affects usually one dermatome, so they'll have it on half of the side of the body. Usually before they get the actual vesicles, they may complain of, my skin hurts. I've had people tell me that it felt like they had a burn on their skin. I have actually had a couple patients who have come in who have told me they have had rashless shingles, where they have shingles without the rash. So very, very hard to diagnose. In fact, they were both misdiagnosed. One, they thought they had sciatic issues. Another one actually was from this area, actually wound up going to somewhere in Virginia because they knew a doctor there, and they were actually diagnosed with rashless shingles. So sometimes you have to think a little bit outside the box, that if they're complaining about this skin pain and whatnot, but you're not seeing the actual vesicles erupt, there have been cases of rashless shingles. And to be honest, I don't know if it's more prevalent in people who've had the shingle shot or not, that it's maybe a lesser version of it, but it is out there. So anytime that you have somebody that has a herpes zoster case, one, we worry about it getting in the eye. Again, because if it does get in the eye, it does tend to scar the eye, and it tends to be permanent scarring. So anytime a person has herpes, especially on the face, usually 10 to 25% of them will get it in the eye. So obviously you see the crusting around the eye. The rule of thumb is there's something called the Hutchinson sign, and the Hutchinson sign is if it gets to the tip of the nose, the odds of it going into the eye are quite high. It doesn't mean it is going to for sure go in the eye, but they're definitely at a greater risk. 1/3 of patients without Hutchinson sign can still get it in their eye. But if you have Hutchinson sign, you're twice as likely to have the zoster go into your eye. So anytime you have anybody that has zoster on the face, it is not a bad idea to send them to an optometrist, ophthalmologist, to have a look at the eye just to make sure that it's not real close to the eye. You will not see it in the eye if you do not have an instrument called a slit lamp that you can look with some magnification in the eye to see what the cornea is doing, because it will attack the cornea of the eye. These are pictures of different people with Hutchinson signs, different degrees. Obviously this person down here, pretty mild presentation, or obviously this one just is nasty presentations. Yeah. So when we see somebody with zoster, one, even if it's not has to do with the eye, we want to put them on an antiviral within 72 hours of the onset, just to help prevent the risk of post-herpetic neuralgia. Post-herpetic neuralgia is people who get shingles or zoster and they're not put on an antiviral because of the damage that that virus does to the nerve that it's affecting. These people, once the shingles goes dormant again, once they're over their flare up, they can have constant pain of that nerve for the rest of their life. With the zoster in the eye, when we have zoster in the eye, we treat it with a steroid. When we have herpes simplex in the eye, we never treat it with a steroid. So anybody that you see that you think has a herpetic infection, you should not treat them yourselves unless you have a slit lamp and you can confirm this is a herpes simplex infection, this is a zoster type of an issue, because the treatments of the two are absolutely opposite from each other. Plus, when we see somebody with a regular virus of the eye, not even being herpetic at all, we tend to put a steroid in to make these people feel better. If you put a steroid in a person that has a herpes simplex in the eye, you're going to make the herpes simplex even worse. So any question of could this possibly be a herpetic type of an infection, you definitely want to refer it out so you can get confirmation of yes it is, no it isn't. There are, I just want to go back for a second. I think on here, I don't see my slide. For somebody who does have herpes simplex, there are two drops that we tend to use. One is called trifluridine. It used to go by the trade name Viroptic. It is very difficult to find it. And I shouldn't say it's very difficult to find it. It's very difficult to find it the day that you need it, because it has a 14-day shelf life and it has to be refrigerated. So normally when I see people who come in with a herpetic infection, I normally inform them immediately, this is a drop. It is going to take your pharmacy 24 hours to get this drop in for you to use, because very seldom does a pharmacy carry it on site because the shelf life is so short. Every now and then, if I have somebody who is just really, really flared up, I will call around to pharmacies, and every great once in a while I'll find, perhaps the CVS happens to have a bottle laying around that then, the patient can go and pick it up. But most likely, this is a drop that is going to be a 24-hour waiting period for these people to get on it. There is also a very thick gel drop called Zirgan that you can use with people with herpes simplex. It tends to be very, very expensive, where the Viroptic is generic. So the Viroptic, the dosage of that is you're going to take one drop 5 times a day for a week. And then once you look at their eye, see that their eye is getting better, I usually then have them take it a couple times a day for maybe 4 or 5 more days, depending on how their eye looks. The Zirgan, because it's a thicker drop, it's more of a 3-time-a-day type of a medication. There again, even though it has a longer short life, because it's so expensive, a lot of pharmacies don't carry that either. And as long as they're waiting 24 hours, you may as well be, friendly to the patient and give them a drop that's a little bit more economical. This slide that I have on here, significant overlap in symptoms, I just put on just so you can see there is a lot of overlapping in symptoms. So listening, looking at the symptoms, I try to, when I have a patient come in and I'm asking them questions and they're describing things, I try to, before I even look at their eye, I try to figure out just from what they're telling me, okay, I think that it's between these 3 things that they have. I try to formulate a really good idea of what they have before I actually look. And then certainly, as you see things, you're going to find with any field, some people are really bad at describing things. So it's a constant asking them questions, trying to ask them to describe, my eye hurts. Okay, great. How does it hurt? Is it a pokey feeling? Is it a scratchy feeling? Is it a bruisey feeling? All those different types of symptoms, if we can kind of fine tune them, really help you lead to a diagnosis. Okay, now I'm going to go into a little bit more of, I don't want to say so much chronic conditions, but these are more conditions that very seldom do people come in like as an emergency office visit of, hey, there's something wrong with my eye. These are usually conditions that you're going to see in a regular population where maybe somebody's not even aware that they have them. It usually isn't something that requires immediate action, but definitely things that you're going to see in patients that come in. One of these that's really common is something called chronic blepharitis. Chronic blepharitis is an inflammation along the lid margin. It is actually a skin condition. So it is related to cradle cap. It is related to sebaceous issues of the skin. People who have dandruff issues, flaky skin, they tend to be a little bit more prone to developing this. We also see it in a population that may not be, I don't want to say it's an issue with hygiene, but a population where hygiene may not be the greatest. We see this a lot in nursing homes. And I also see this quite a bit in young kids. Young kids, usually have a phobia against soap and water, especially around their eyes. And so basically what the chronic blepharitis is an inflammation along the lid margin of the eye. And basically what's happening is the skin is becoming irritated, it's sloughing off dead skin cells, or it's overproducing skin cells. And what happens is those skin cells get trapped in the hair of the eyelashes. As those skin cells get trapped along there, bacteria builds up in there, debris gets built up in there, and the eye just becomes very irritated. Because there's bacteria that builds up in there, what happens to these people is, especially overnight as they're sleeping, bacteria releases toxins. The toxins get into the eye, which irritates the conjunctiva. So these people often complain that, my eyes are really red in the morning. They're kind of scratchy in the morning too, because some of these dead skin cells, there's such a big buildup, they start flaking off into the eye. So then they almost get like a foreign body sensation. They may complain that their eye feels gritty. If you look at them, you can see that their eyelid margins look kind of reddened, right where the eyelashes come out of the eye. Some people have this as a chronic condition. It doesn't matter how clean they are. It doesn't matter what their hygiene is. They just chronically have this issue around their eyelid margins. My son is one of these kids. And it can come and go. And I can tell when he has his because I'll look at him and I'll say, your eyelids right on the edges are red again. Your blepharitis is getting worse again. So the treatment of something like this, these are just some slides that show some blow up pictures. You see all these little flaky things right here. These are just dead skin cells that are building up. And then because, as I mentioned, because of it, the irritation, you're going to get mucus mixed in with them. It can look kind of wet and thick depending how much mucus, or it can look really dry like they have grains of sand along their eyelash margins. So the treatment of this is we need to get rid of those dead skin cells that are trapped in the eyelashes. So lid hygiene. Some people like to use baby shampoo. Take some No More Tears baby shampoo, put a drop in your palm, dilute it out with some water, and actually shampoo the lid margins of the eye. Take a nice hot washcloth, kind of work it in there, and what I tell a lot of people is you don't even need the baby shampoo. If you just take a nice hot washcloth and just gently kind of massage and just try to scrub, and you don't need to do it hard, but you're trying to remove those dead skin cells that are built up along the eyelash margin. The problem with a lot of elderly people is we lose our near vision. We can't see it. So it's, you're kind of asking somebody to do something to something they can't see. So it is a little bit harder for an elderly person to deal with this. Because it makes their eyes feel gritty, sometimes we'll tell them, you know what, you can just put some artificial tears in your eyes. That will help with the grittiness. I find this is a great time to use the erythromycin ointment that you mentioned before, because they do tend to have kind of a chronic, low-grade type of bacterial infection mixed in with this. And the type of drug that the erythromycin is, as well as tetracyclines, they work really well on glands, on oil-producing glands. They work really well on skin. So I'll tell them, put a little bit on your finger and just rub it into the base of your eyelashes when you go to bed at night. I don't have them use it during the day just because of the messiness factor with the ointment, but I tell them every night, go ahead and use it when you get up in the morning. Nice hot compress, wash off the extra greasiness and whatnot, and and go about the rest of the day. People will find once they use this ointment, usually after about a week or so, they will normally find, oh my gosh, my eyes look better, my eyes feel better. What I tell these people to do, because this usually is a chronic condition, don't stop the ointment, but you don't need to use it every night anymore. And I'll tell them, experiment. Let's use it twice a week and see if you can keep this from coming back. If they use it twice a week, hey, it's not coming back, my eyelids still look great, they still feel great, then I'll tell them, you know what, let's just try using it once a week. And if they can use it once a week, keep it from coming back, great. If they go down to once a week and say, no, you know what, it's starting to come back a little bit, you know what, then you need to use it, let's go back up to twice a week, or let's go back up to 3 times a week. But this does tend to be a chronic condition, so once it does go away, it usually will come back at some point in time if they don't keep up with the maintenance of the eyelid margins. So ilotyson is my favorite. To use with this, it's bland, it's safe, it seems like very few people are allergic to it, you can use it long term. Azosite is it's a drop, and basically azosite is a drop form of zithromycin. I don't like it as much. One, it's expensive. 2, you're asking these people to put a drop in their eye, which I think is a little counterintuitive because it's an eyelid issue. The bottle itself is only 2.5 mLs. You go through it pretty quickly, and usually with blepharitis, it's a chronic condition. So I do not like to prescribe azosite. It's way more expensive. It's more short term. Maybe if you have a patient who is going to have some type of eye surgery and the surgeon tells them you need to clear up these lids before you can have surgery, we need them cleared up ASAP, maybe then I would consider using azosite. I just use ilotyson. I just find ilotyson works in just about everybody. Avenova is a newer prescription medication. It's a hypochlorous acid. So basically it is bactericidal. It is a spray bottle, and what you do with that is you have the patient just close their eyes. It's a very fine mist. Spray the bottle towards each eye, 1 spray in the morning, 1 spray at night. It's usually a pretty fine mist that it's not dripping down their face or anything. If they want to take a little tissue or whatnot or rub it in, I find they don't really need to. This works really, really well also with some patients who do not want to use ointment. There are some people who just don't like using ointment, and I find that this works very, very well. I've had a couple people who've become allergic to it, and that can happen with any type of medication, but I found the people that I've given it to really like it. Next thing we're going to go over is hordeolum. Hordeolum is basically a stye. Most people know, stye by stye, not a hordeolum. And basically, it's an abscess of the eyelid, of a gland in the eyelid. You can have them internal, so they're more inside the lid or underneath the lid, or you can have them externally. That's probably the more common one that we see. And it affects different glands, whether it's internal or external. If you see an external stye, what I tell patients, also with an internal one, it basically is a pimple. It is an abscess of a gland. A gland is blocked. It's got a buildup of bacteria that's inside of it. There's a little focal bacterial infection that's going on inside there. People who have these will usually complain that my eyelid hurts because that gland is swollen. If you get an abscess anywhere on your skin, when you touch it, it hurts. So with a stye, with a hordeolum, usually their number 1 complaint is going to be, my eye hurts, and that's when you ask, is it your eye or is it your eyelid? Well, it's my eyelid. Usually along with it, the eyelid will be swollen because this gland is draining. It starts from the very upper edge of the eyelid and drains downwards. So if you have a plug down here, you have a backup of all the fluid and whatnot that normally flows out of that gland. It's all backed up. It's got nowhere to go except in your lid, so it's going to give you a big puffy lid. A lot of times these people will come in and say, gee, last night my lid was puffy and now today I have this little spot on it. And this is the hordeolum or the stye itself. These are all external. right here. They may complain that their skin is itchy because anytime your skin stretches, it gets a little bit itchy, but that usually is not your hallmark. Usually pain is what your hallmark is going to be. And basically, once you free this plug, the gland will drain. So it basically is a matter of how do we get this plug out of the gland. This is an internal one. Pull down a lid. And you can see that instead of this draining outwards, it's draining inwards. So this is an internal hordeolum or internal sty. So when we see these styes, what we like to do is we like to tell people hot compresses. What a hot compress does is it dilates, it makes things get bigger. So we want to try and open that gland up. So whatever got in there to plug it up, we want it to flow out. So a hot compress can help with this, and a lot of times, if caught early, it doesn't need any other treatment besides a hot compress. That can usually do it. If a hot compress by itself, if you have a patient who comes in and says, I've been doing hot compresses for 2 days and it's not getting any better, then I would also add the erythromycin, the iloticin ointment along with it, because that can help quite a bit also. Usually if you're going to use a hot compress, if it's going to work with a hot compress, usually within 1 or 2 days, their symptoms should be greatly reduced. They should start noticing that it is going down in size. As I mentioned before, if they've come in and they've been doing hot compresses already for a couple days, and you still see that lump, they're still in some discomfort, you need to add something else to it. The hot compress alone is not going to do it. What can happen in some people is over time, you have that gland that's clogged, you have that abscess in there. Over time, the bacteria has nothing to feed on anymore. And so the bacteria actually dies off all by itself. And then what happens is these people are left with this lump on their lid, and it's just basically a ball of mucus. It no longer hurts anymore. But they may come in and say, you know, I had a sty and I thought it went away, but now I have this lump on my lid. These are called chalazions. And basically what happens is all that stuff that was backed up in that gland, it all kind of comes together and it coalesces into one large lump inside that gland. So these are usually never painful because they're not infectious anymore. You can feel it, and when you feel it, it feels like there's like a hard little nodule inside there. You know, you can actually feel like a hard lump of mucus in there. So for treatment, you know, as we mentioned before, the hot compresses for the styes, the topical antibiotics. If you have a sty that does not respond to a topical antibiotic, you can add a topical steroid, and usually that will take care of it. If it's a chalazion, so with the chalazion, it's not infectious anymore. So putting a topical antibiotic on it is going to do absolutely nothing because the infection pretty much burned out. So with a chalazion, you instead want to use a topical steroid because we want to dissolve all that old inflammatory cells that are just sitting in there. With a chalazion, if it does not respond to a topical steroid, one, you can do a steroid injection. I don't think a lot of people do that. It is very easy to have these things removed. You'd actually have to send them to an ophthalmologist, and basically what they do is they make an incision on the underside of the lid, and it is like opening up, you know, the little can of worms that bursts out. You make a little incision, there is so much pressure inside that gland that it just expels out and instantly gone. And very, very easy to do. Now, I've had a couple patients, one recently, deathly afraid of needles. Deathly afraid of needles. Has a chalazion and will not withstand a steroid injection. The topical steroid did not work with him. There was no way he was going to go and have it surgically drained. There was just no way he could do that. I mean, he just knew, I can't do anything that deals with needles. So for these people, a lot of them will respond well to putting them on oral doxycycline. Doxycycline oftentimes is used as an acne medication. It works really well on clogged glands, and I actually put my patient on oral doxycycline, and it actually dissolved. It took about 2 weeks to dissolve his chalazion, but it did, and he was thrilled to death because he was ready to live his life with a great big old lump on his eye, and he was willing to just keep it there because there was no way he was having that thing drained. So for ointments, steroid ointment, there's Tobradex ointment. There's also an ointment called Maxitrol, which is generic. And basically I tell them apply it to the lump on the lid. I tell them to do it 3 times a day. Again, ointment during the day, not fun. I tell them to use it very gingerly throughout the day, but at nighttime to really lube it up. It's an ophthalmic ointment. I tell them it's okay for it to get into the eye. And in fact, if they have an internal sty or internal hordeolum, I will actually tell them, put the ointment in your eye. I'll tell them, put it in the lower lid, put about a 1/4 inch strip in the lower lid, even if the sty is in the upper lid. What happens is that ointment will melt and it will gravitate to where it needs to be. But if it's an internal sty, it will penetrate the underside of the lid more quickly than it will the outer side of the lid. Okay, let's say you have a patient that comes in and says, you know what, my eyes water all the time. And usually these people tend to be more elderly, not always. I mean, you can have younger people with tearing complaints. It can be unilateral or bilateral. They might say it's more common in the morning or after being outside, working on a computer. You know, really no pain in the eye, there's no mucus going on. It's just that their eyes water. Usually, you know, like I say, bilateral, can be unilateral. So, you know, obviously you start thinking, okay, there's no mucus. It's not going to be a bacterial infection. Is there itching? Nope, there's no real itching. Probably not an allergic type issue. Any pain involved? Nope, there's no pain. Okay, I don't think then it's a viral conjunctivitis. So those are kind of the main conjunctivitis right there. Could it be a herpes type thing? You know, yeah, there's pain or there's tearing involved. Yes. Are you light sensitive more than normal? Nope, I'm not light sensitive, so probably not a herpetic type of reaction. Usually what it will be is dry eye. Dry eye is very, very common. And the number one symptom of dry eye, when I tell people who come in and they complain that their eyes are tearing all the time, and I tell them, you have a dry eye, they all look at me like, I don't think you're listening to me. I'm telling you that my eyes are watering all the time. And the reason why their eyes water all the time is when an eye becomes dry, it gets very irritated. When our eye becomes irritated, our eyes send a signal to the brain saying, hey, we're irritated. The brain sends a signal back to the eye, okay, if you're irritated, the only thing we can do really is to tear. So just start tearing a lot. So what happens in people who have a dry eye is they get what's called reflex tearing. Their eyes are constantly tearing to kind of help solve the irritation. The problem is our tears that are normally in our eyes usually have a lipid layer. It usually has a water layer. It usually has protein layers. So there's different types of layers in our tears. Reflex tearing is strictly just water. So it's not the same consistency of our tears. We need a lipid or an oil layer of our tears. It keeps the tears in our eyes. It keeps them from evaporating out. When you have just watery type tears, they're just going to drain out of the eye. They're just going to fall out of the eye. They're going to evaporate out of the eye. So they don't really make the eye feel moist. It actually makes the issues even worse. So probably about 11 to 22% of people have chronic dry eyes. Lack of estrogen, women who go through menopause, huge symptom. People who have Sjogren's syndrome, they have very dry mouth, they have very dry eyes. Some people have a defect in the way that they blink. They might not close their eyes all the way. When you don't close your eyes all the way, part of your eye is constantly exposed to the air, and that can lead to a chronic dryness of the eyes also. People who've had Bell's palsy in the past, their eyelids may not work as well, and that can lead to a secondary dry eye. Also, I've seen women who've had blepharoplasty, had lid jobs. their plastic surgeon got a little bit too exuberant during the surgery and they can't close their eyes all the way. And that leads to a very chronic dry eye because when they're sleeping at night, their eyes are not closed all the way and they have chronic exposure of the cornea to the air, and that's very irritating. So treatment of dry eye, artificial tears, look at their lids. Is there a defect in the way that their lids are? Do they possibly need some kind of corrective lid surgery? There are 2 medications on the market for dry eye now. One is for stasis. There's a brand new one called Xiidra. Both of them target inflammation. They think somehow the inflammatory cascade helps lead to dry eye. But most people usually, if they use a good artificial teardrop, you don't want them to use any kind of drop that says get the red out because that will make the eye more dry. But usually just with regular artificial tears. And these are just some prescriptions for the dry eyes. All right, acute angioedema. If you see someone coming in looking like this, very, very puffy eyes, they'll normally tell you, like it just happened out of the blue. Very quick. It didn't take days for this to build up. They'll say, you know what? Like at lunchtime I was fine, and by dinner time I looked in the mirror and this is what my eyes look like. Very puffy, very full feeling. These pockets are just filled with fluid, so obviously their eyes are going to feel very heavy. Usually it's acute angioedema. This is usually caused, it's a severe allergic reaction. So we have our most severe allergic reactions around the eye when it deals with protein. Our eyes, our bodies have one type of protein. Living matter has different types of protein. Plants have different proteins than animals. So when we get a foreign protein in our eyes tend to sort of overreact and create this angioedema. So normally when you see a person with this, the first thing to think of for a causative agent is something living. A bug bite. Did a bug fly in the eye? Did they get stung by something or whatnot in the area of the eye? The other big thing, believe it or not, poinsettias. Poinsettias, the protein that is in the sap of poinsettias is very, very, I don't want to say irritating to the eye, but it just creates this huge inflammatory reaction. So usually every year around Christmas time, I will see a couple people that look like this, and it's usually the poinsettia plant that does it. Usually it's painless. They might, just looking at that, they might say, well, maybe a little soreness because the skin is so thick and heavy and whatnot. Usually it doesn't really need any treatment. You can tell them if they want to take like an oral allergy medication. It's just, okay, one, if it's from a plant or whatnot, you need to get rid of it and not be exposed to it again. If it's a bug bite or something like that, you may want to topically treat that bug bite area with, a steroid, or, you can even do an oral steroid if their symptoms are severe enough. But usually, once they remove themselves from the offending agent, it goes away pretty quickly. Contact dermatitis, very similar. Again, another allergic reaction, but you don't have that severe swelling with it. Contact dermatitis is very, very common around the eyes because the skin around our eyes is thinner than it is anywhere else in our body. So you can have an allergic reaction to, let's say, shampoo, and your scalp will be fine. You won't have hives or anything, but you'll get a contact dermatitis right around your eyes. So when you see somebody with a contact dermatitis around their eyes, it not necessarily is something that they are using on their eyes. Most likely yes, but not necessarily so. These people complain of puffiness around their eyes. It can be a little bit painful because over time, the skin starts to become kind of irritated. They can have these little eruptions, little cracks in their skin. Usually when you look at them, their skin, the best way I can describe it, looks like alligator skin. You see all these little folds. It looks leathery, usually by location. In this slide here, all of her irritation, well, I shouldn't say all, she's got a little bit down below, but very isolated around the eye right here. This most likely is a product that she's using on her eye, possibly even her mascara, because look as she closes her eyes, her eyelashes are touching down here, and she's got a little bit of reaction down here as well as up above. So first thing if I see somebody looking like this, first thing I say to them is, okay, have you done anything new? Now, the biggest misconception with an allergic reaction is, one, it not necessarily is anything brand new. To develop an allergic reaction, you have to be exposed to something for a period of time, and that period of time is different for every person. But your body then has to decide, we don't like this, and it develops antibodies against it. So if someone is allergic to something, it has to be a product that they've been using for at least a week or so. So, and it could be something that they are using long term. A lot of people think, well, I've been using this forever. It doesn't mean you can't become allergic to it. But the most common culprits are something that they've started within the last, I usually say, couple months. Has anything reformulated? Have you changed any of your makeup products? Have you tried a different color of your, it might be the same brand of eyeshadow, it might be a different color of eyeshadow. So obviously I start with those types of things. This woman over here, she's got more of a reaction down below her eye. When you see more of a reaction down below the eye like this, the first thing I think of is an eye drop. She's putting in an eye drop. What happens when you put in an eye drop? You tear. Your tears go downwards. So usually if it's very isolated down below the eye, for this type of person, the first thing I would ask is, are you using some type of eye drop? And that would be my first choice of, okay, yes, no, is she not? Most likely she probably is. If not, then we need to think of other things. One of the great things when you see these people, one, they're usually quite irritated just because of the feeling of having this allergic conjunctivitis or dermatitis. But also, most women don't want to walk around with big red puffy flaky looking eyes. So they're really bothered by the cosmetic of the whole thing. So triamcinolone is a cream, or you can get it in a lotion form also. It is great with repairing the skin damage from a contact dermatitis. It heals the skin very quickly. I will prescribe it for some women. The bad thing with it, however, that I inform my patients, this is going to mask your allergic reaction. So these people, once they use this triamcinolone, it's going to make their eyes look better, but if they do not get rid of the offending agent, it is just going to keep coming right back as soon as they stop using it. Any type of steroid cream, if you use it around the eye for a long period of time, steroids can thin the skin. When you thin the skin around the eyes, it's going to give you dark circles around the eyes. So I tell my women patients, if you use this chronically, you can end up with dark permanent circles around your eyes. And that usually alone is sort of incentive enough for them to, maybe let me first try and figure out what this is before I use this. Every now and then I'll get somebody where, I need to go to a dinner party tomorrow night. I want this to start looking better. They'll go ahead and take the cream, but I definitely let them know that this is something you do not want to take chronically. Steroids can also cause cataract formation and glaucoma. So we definitely don't want people chronically using steroids around the eye. Real quickly, I'm just going to go over preorbital or preseptal cellulitis. This is more common in kids. And what you will see upon presentation is sort of you might think, wow, could this be an angioedema? Very, very profuse swelling around the orbit. It just looks really nasty. Oftentimes it'll look red, it'll feel warm. These kids usually don't have any fever. They'll be uncomfortable just because of all the swelling. Usually one of the hallmark signs is I'll ask them, does it hurt when you move your eye? So when they move their eye back and forth, if they really complain of, oh my gosh, that hurts real bad, that's more of a medical emergency because that could be orbital cellulitis, which requires hospitalization. So if someone comes in and you see this great big old eye, usually it's a kid that actually doesn't feel sick. just, wow, my eye blew up. It's a little bit tender. It feels a little bit warm. But usually systemically, they're not going to have a fever. They're not going to have pain with it. And usually this is also caused from a bite, an insect bite. It's a local inflammation on the frontal structures of the eye. They could have an upper respiratory or an ear infection that spread. And with this, we treat with a systemic antibiotic. If you're ever not sure though, absolutely refer them, because orbital cellulitis, there is a very thin barrier between the orbit of the eye and the brain behind it, that anything that we suspect could be bacterial behind the eye, we definitely, want to make sure that they get the appropriate antibiotics, and you don't want to fool around with that. So antibiotics work really well with this, depending on if the patient's allergic to penicillin or not. There's a whole host of different antibiotics that can be used for preseptal cellulitis. This slide I put in here, not because this is any type of emergency, but every now and then you might have a patient who comes in and you'll see these kind of yellowy, they can sometimes look orange, little plaques on their eyelids. I'm amazed sometimes people who come in, they don't even mention that they have them. I mean, you obviously see them. And I will ask them, do you know what that is on your eyelid? And I'm shocked at the number of people who say no, but they don't bother asking. And I will just let them know it's called xanthelasma, and it basically is a deposit of cholesterol. It tends to run in families. We see it more in kind of olivey skinned people. Usually it's located medially towards the nose. It can be bilateral, not necessarily. It does not necessarily mean they have high cholesterol, but there is a pretty high relationship between the two. So if you do see it, I just tell my patients, you know what, this is what it is. If you haven't had your cholesterol checked, you may want to do a lipid panel on them just to make sure that their lipids are in good numbers. It can be removed by a dermatologist. They can remove them, but they do, people who are prone to get these, if you remove them, they tend to just keep developing more and more of them. Arcus is another thing. If you have an elderly person, we normally see this in an elderly person, just looking nakedly at their eye, you'll see this white ring at the edge of their cornea, and that also is lipid deposits. And so if you see a person with that, again, you may just want to do a lipid panel on them and just make sure that their cholesterol is where it should be. Pinguecula, this is a benign thickening of the sclera. If you look at yourself in the mirror, you will probably find a pinguecula on your own eye. It is a little localized thickening of the conjunctiva that's on top of the sclera. And it's our body's protective mechanism against sun exposure and wind exposure. If you've been outside a lot, you're going to have these little yellowy plaques. It's just a little bit of thickening of the tissue right there. They can vary in size. They usually don't grow real large. Every now and then you may have somebody come in that says, you know what, when I blink, it's kind of like irritating me. And for someone like that, you can tell them, just put some artificial tears on it and whatnot. Every now and then they might get a little bit inflamed. You can give them a little steroid. Usually just artificial tears are enough, but they're very benign. They don't develop into anything. They don't grow into anything. Usually you'll see normal structures of blood vessels underneath it. There's usually not a special blood supply that's going to it, so it is a way to differentiate it from anything that could be cancerous. Pterygium, same thing, another growth that we see. It's benign, however, this can cause more of an issue. Obviously, when you see something like this is going to affect the vision because it's in the visual axis. And this too is an overgrowth of the tissue of your eye in response to UV exposure. They call this surfer's eye. Around here, we don't see it a ton because, we just don't have that intense sun around here. But every now and then, I tend to find that it's more common in men versus women. And it's way more common on the nasal side. I've never seen one to this degree. Sometimes they'll see like a very slight. And I'll usually just tell people, you know what, you just need to be very cognizant of, the UV exposure, wearing good sunglasses, artificial tears if they feel like they can feel their lid blinking over that. It can be surgically removed. However, oftentimes when you do remove these, they have a big tendency of coming back. So we generally don't remove them unless they start affecting vision. This next slide is episcleritis. You may have a person who comes in that complains that they have this red spot on their eye. They might complain that their eye burns a little bit, but they'll definitely, and you'll see, they'll have like this very isolated, just real red area on top of the sclera. Usually we see this in younger adults. And it's usually just a benign inflammation of the blood vessels that are on the surface of our sclera. They're called episcleral blood vessels. And, you know, they could have been out in the wind for whatever reason. It irritated the blood vessels. They inflamed a little bit, and this is what you get. Sometimes if they just take an oral ibuprofen, it can get rid of it. If they've tried that and it doesn't seem to be going away, it responds very, very quickly to like a topical steroid. Just give them a very mild topical steroid drop. Sometimes even artificial teardrops will make it go away. And these are just some prescriptions that you could prescribe. Oral prednisone, normally you don't need to go to that degree with this. If you do see somebody that has a recurrent case of episcleritis, let's say they have it, a couple months later, you notice they're coming back, they have it again. There is a big relationship between episcleritis and rheumatoid arthritis. So if you do see it recurrently, start thinking of the rheumatoid arthritis types of disease or connective tissue diseases. Scleritis is an inflammation of the deeper blood vessels of the sclera, much more red, much more widespread. These people are in pain. They're usually not going to a general doctor's office for this because their eye hurts so bad. They're usually ending up at an eye doctor's office. So, you know, just know that there is a case like this out there, and this usually needs an oral medication to treat this, not a topical medication, because it's the deeper blood vessels of the eye. Again, associated causes can be rheumatoid arthritis, connective tissue disease, a lot of the itises. The inflammatory diseases are what can cause these recurrent red eyes. And this is an example of a non-steroidal anti-inflammatory. I'm going to real quickly just go over malignant eyelid tumors. Just like anywhere in the body, we can see cancer on the eye. Most common is going to be the basal cell, and very common for basal cells to be on the head or the neck. 90% of them are on the head or the neck, and it accounts for 90% of the lesions that we see on the eyelids. And even though you might think, oh my God, a cancer on the eyelid, they're actually very treatable. And cosmetically, you'll never know if somebody had a repair of a basal cell on the eyelid. You'll never know after the repair was done. Just like any type of basal cell, you tend to get this rolled kind of glossy border, a little bit ulcerated, hallmark on the lid margins. If something is cancerous, it will usually destroy the eyelashes in that area. So if you see, it's very common for people to get warts along their eyelids. If you see a wart along the eyelid, their eyelashes are very normal. The eyelashes grow right on top of the wart, right through the wart. If you have a cancerous lesion, there will be no eyelashes. It completely destroys the hair follicles. So it's a good way to differentiate. Anything that disrupts the eyelash growth itself probably would need a referral. Here's an early one, and you can see, you know, yes, there's still eyelashes down here, but if you look, we have a couple rows of eyelashes, and there's absolutely no eyelashes underneath where this is growing. Obviously, this is much more advanced. And these usually be very slow progressing. Squamous cell, you know, just like on anywhere else in the body, this is much more invasive. You know, certainly seeing something like this, I mean, you obviously know this needs to be referred to. Usually we send these to like an oculoplastic surgeon that works around, you know, the eye, as well as a dermatologist. This is a squamous cell cancer that is on the conjunctiva itself. I've actually had 3 patients that have had this. It is not uncommon. Definitely, you know, you might look at someone's eye and think, boy, is that a scleritis? An episcleritis? Is that possibly a puncula? Normally when you see this on the eye, You see all these big feeder blood vessels that are going into it, and there's usually these raised plaques of tissue that are along with it. Usually when you see something like this, you just kind of know this does not look normal. There's usually no pain whatsoever with these, and they usually tend to be pretty fast growing. If it's smaller and you're not quite sure what it is, oftentimes what I'll do, I had a gentleman who had one, he presented very early, put him on a steroid drop, which seemed to make it go away, but then about 2 months later he came back in, and it was back, and it was even a little bit larger. And because it grew that quickly in that short amount of time, and this isn't his picture, I certainly referred him out, and sure enough, that's what it was. And he actually had it removed. Very easy to remove these, and looking at him, you can't even tell that he had anything on his eye at all. Melanoma, just like with the rest of the body, you can have melanoma of the eye, of the eyelid. You can actually have melanoma of the retina. Absolutely, it has to be referred out. We do not like to see melanoma in the eye because it's one step away from the brain. So depending on how severe it is, where it's located, melanoma used to mean immediate enucleation of the eye. Now we actually do radioactive plaques embedded inside the eye. If you have any type of recurrency of melanoma in the eye comes out. All right, a couple more things with the lids. Ectropion. This is not a medical emergency, but you may see, I see this a lot in farmers. Older men who are farmers, they come in and they have, I mean, this is the way his eye is normally. He's not pulling it down or anything. And what really kind of surprises me is I'll see these people come in like this, and it kind of surprises me that like their general practitioner or nobody has addressed this issue, that his eyelid is down like this. And yeah, okay, one, you might think, well, it's a cosmetic issue. The guy's a farmer. He doesn't really care what it looks like. But what happens is this conjunctiva that's underneath here is chronically being exposed to the air, and it will eventually scar, and it will become very tough. And this person will have just severe dryness issues. He'll have constant infections of the cornea because we need that moisture in our eyes to help prevent and to help fight bacteria. So this just leads to a lot of chronic issues down the road. So if you ever see anybody that has this, it's called ectropion, the outward turning of the eye, highly, highly recommend that you refer him to an oculoplastic surgeon. And what they do is they just tighten up the skin to roll it back in the way that it should be. Likewise, you can have somebody with entropion, which is the inward turning of the eyelid. This is actually quite common as we age, and I've had a handful of patients who just woke up one morning and this is what their eye looked like. It is incredibly painful because you have the whole row of eyelashes scraping on the eye. So for those of you who get an eyelash in your eye and you think, oh my God, I got an eyelash in my eye, it hurts. Imagine having, 30 eyelashes in your eye all at the same time. So these people usually will wake up in immediate pain. Looking at the eye, one, their eye's a little bit watery. Even though you're looking at this on the slide, this is really quite magnified. When you look at this person normal, you might not really see that, oh yeah, their eyelids turned inside out. You still see eyelashes and whatnot, but in a lot of these people, you don't see it. I also had a patient just recently who came in, complained about this. So one thing you have in your armament is you have your fluorescein dye. If someone's coming in and their eye hurts, put a drop of fluorescein in. Is there a foreign body in there? So when you put the fluorescein in, you're going to see that this whole portion of their eye just glows because all these eyelashes are scraping against it. Well, I had a patient not long ago where the whole lower part of his eye just glowed, but his eyelid was normal. So I looked for a foreign body. I did not see a foreign body. So as I'm looking for the foreign body, I'm having him look up and I'm having him look down. And sure enough, when he looked up, his eyelid flipped in. But then when he looked straight ahead, it flipped back out. So you can have these conditions where an eyelid may temporarily flip in, and when your eye hurts, what do you do when your eye hurts? You rub it. And what he was doing at home is it would flip in, he'd rub his eye, it would flip out. But then when he would look up later on, it would flip back in. And so he couldn't quite figure out what was going on. So in this case, the staining pattern, of the fluorescein kind of led me to believe something is rubbing against this guy's eye, and that's what we discovered. All right, cataract really quickly, because cataract is the most common condition that you are going to see in elderly people. Every single person on the face of this earth develops a cataract. No matter who you are going to have a cataract. A cataract is a clouding of the lens in your eye. The lens in your eye is made out of protein. As protein ages, it gets cloudy. So when you have a patient who comes in, do I have cataracts? If they are over the age of 55, I guarantee you they have cataracts. What we don't understand is in some people, cataracts blur their vision. And if it blurs their vision and we can't get rid of the blurriness, those are the people that have cataract surgery. If a person has cataracts and it does not blur their vision, they don't have cataract surgery. We don't need to remove the cataract. It does not harm their eye at all. So when a person first gets a cataract, normally the first thing they think of is, oh, my glasses must need to be changed. My vision is blurry. So as a cataract matures, it actually does change their prescription. So a person becomes more nearsighted. They have a harder time seeing far away. It also creates a lot of glare. Instead of the light passing through their lens, the light coming into the eye is now being scattered because it's hitting all these cloudy strands of protein that are in the lens. So when we look in the eye for a cataract, this is a view in the eye, and you can get the same type of view using an ophthalmoscope. This right here is the lens, and you can't see the backside of it, but you can see normally the lens is clear, so you would get maybe an appearance more like this right here for clear. It's going to look almost gray. But then as the lens gets more cloudy, it turns kind of a milky whitish yellow color. And then it progresses from a yellow to an orange to a beer bottle brown in color. And as that cloudiness progresses, usually for most people, your vision decreases. But as I mentioned, if it doesn't decrease your vision, we just leave them alone. Cataract surgery is the most common surgery done out of any surgical procedure of any part of the body. It is a very easy procedure. It is a 15-minute outpatient procedure. You have one eye done. About a month later, you have the other eye done. It is not done with a laser. I don't know why everybody thinks cataract surgery is performed with a laser. And because there are no pain nerve endings in the eye, it's absolutely painless. So people are not put to sleep for this. You're given usually Versed or put in a twilight like you are during a colonoscopy. People who are on blood thinners, they don't have to go off blood thinners or whatnot. It's a very non-invasive surgery and they instantly can see. So it is like a miracle for some patients. Glaucoma is another disease that you will hear with the eye. Glaucoma is having elevated pressures inside the eye. Your eye is filled with a fluid called the aqueous humor. In the back of the eye, it's called the vitreous humor. But the aqueous humor, which is in the front part of the eye, you are constantly, at a much quicker rate versus the vitreous humor, you're constantly producing new fluid. The old fluid drains out of the eye. If the old fluid cannot drain out of the eye quick enough, or if you're overproducing fluid for some reason, it's building up pressure inside the eye. And when you get too much pressure inside the eye, it suffocates the optic nerve and creates the optic nerve to atrophy. When the optic nerve atrophies, you lose your vision. So about 3 million Americans have glaucoma, but less than half of them know that they have it because glaucoma has absolutely no symptoms unless it's incredibly advanced. The bad thing with our eyes is our visual field in each eye overlap. So if we're missing parts of our vision in one eye, usually the other eye will pick up and will cover up that spot. So most people do not realize that they are missing portions of their vision. It's one reason why when you have an eye exam, you are automatically tested for glaucoma, whether you want to be or not. We test every single person for glaucoma. Treatment of glaucoma is usually drops. Most people can stay under control with doing a topical eye drop. If drops do not work, then there are some surgical procedures. Glaucoma is not at all related to blood pressure. However, Like blood pressure, high blood pressure, if you're on drops for glaucoma, you are on them forever. We cannot cure it. We can only treat it and keep it under control. So once you're on a drop, you're always on a drop. What we look at with glaucoma inside the eye is we look at the hole in the center of the optic nerve, which we call the cup. The outer rim, which is your optic nerve disc. This is the tissue that is relaying vision to your brain. So the less of this outer tissue you have, the less vision you have. So, this diagram over here shows a little tiny cup, lots and lots of rim tissue. This is, very good peripheral vision, very good vision. But as the cup inside gets larger, what it's doing is it's atrophying away the rim tissue. And as that rim tissue atrophies, you lose the vision. There are some drugs that can cause glaucoma. Steroids, 30% of the population are what we call steroid responders. This does include people who are on nasal steroids, so a lot of people don't realize the ones that are taking Flonase and the nasal type steroids do have an increased risk of glaucoma. Normally, if it is going to cause glaucoma, we will see it within about 6 weeks after starting medication. So we highly recommend anyone that you start on a nasal steroid, about 2 months after they start, just have them go to their doctor just to get a pressure check and to make sure that their pressures are normal. If you're starting them on a nasal spray and they've never had an eye exam, I would highly recommend that you tell them you need to have an eye exam and make sure your pressures are checked before we start this, because then 2 months later you need to recheck those pressures and make sure that they do not have a rise. There will be absolutely no symptoms. They will not feel like their eyes have pressure. So it's something that a person will never detect. Topamax is a antipsychotic medication. They're using it for depression nowadays. This can cause what we call an angle closure glaucoma. It's a little bit of a different type of glaucoma. It causes a very red and painful eye, and then all of a sudden it develops glaucoma. So normally people who are on Topamax, if they are going to get a glaucoma with it, it's one of the few glaucomas that actually have symptoms. And usually when you're prescribed it, you'll be told, if your eyes start getting red, if they start feeling painful or whatnot, you need to call immediately, because it is a pretty common side effect that can happen with Topamax. All right, age-related macular degeneration. This is all the rage nowadays. We hear a lot about this. It is the primary cause of vision loss in patients over 50 years of age that is not related to a systemic disease. So anybody can get age-related macular degeneration, as long as you live long enough. It's not associated with diabetes. Anybody, you can have perfectly healthy person, not on any medication, and they can get macular degeneration. What is it? It is a progressive painless disease. It affects the part of the eye called the macula. The macula is responsible for your central vision. So it is the most important part of our retina, and that is the part that this affects. And it basically is, it's cell damage. It's aging damage to the eye. I mean, I tell people, it's kind of like when you get age spots on your skin, sort of like the same thing is going on inside the eye. It is an aging phenomenon that happens. Why does it happen to some people and not others? We're not quite sure. We do think ultraviolet exposure, being overly exposed to the sun, can have something to do with that, just as ultraviolet, has issues with our skin. We do think diet has something to do with it. Those with poor diets, tend to not be as healthy and tend to age a little bit more quickly anyways. And progression of macular degeneration can be very slow. It can be also very rapid. There's two forms. One is called wet, one is called dry. The wet form is usually rapid. The dry form is usually slower. Anyone over the age of 60 can be affected by this. If you're a smoker, smoking causes cell damage throughout the whole body. It's going to increase your risk. If you have a family history, it can increase your risk, but not necessarily. The dry is the most common. There's right now no treatment for dry macular degeneration. The good thing with dry macular degeneration is it's so slow progressing that usually a person can go their entire lifetime and not really feel like their vision is very much affected. They usually die before the disease gets to the point where it's debilitating them. Wet macular degeneration occurs in about 20% of the cases of macular degeneration. It causes very fast, very severe vision loss. There is treatment for wet macular degeneration. We cannot cure it. We can kind of keep it at bay. And they get Avastin injections, which is a VEGF. It destroys blood vessels. They get Avastin injections into the eye to kind of slow the progression of it down. These are just some pictures of, this is dry macular degeneration. So you have this pigmentation, and what's happening is the cells of the retina are just kind of atrophying away. So when you get to this last little picture down here, you can kind of actually see the structures behind the retina, just because the cells have just been so damaged. If it was wet macular degeneration, it would look fairly similar, except you would see a lot of blood and a lot of hemorrhaging. So wet macular degeneration is more bloody, where dry contains no blood at all. That's the name dry. All right, diabetes is the leading cause of blindness related to a systemic disease. And usually diabetes is a leading cause of blindness for people really more of a younger age. You know, we call this the working age, usually people below the age of, let's say, 65 or 70. Many of the ocular problems with diabetes are preventable. The key with diabetic retinopathy is early detection. And like most problems with the retina, most diseases with the retina, a lot of people think, oh, if I have an eye disease, I'll be able to tell by my vision. And most diseases that affect the eye, the vision is the last thing to be affected. So diabetes, definitely a relationship between glucose control. People who do not have good glycemic control are going to be much more prone to developing diabetic retinopathy in the eye. Yearly eye exams for diabetics are a must. You know, if you have a good general practitioner or internist that's treating people who are diabetic, I mean, I see my diabetic patients every year. They insist that these people get a report. You know, the doctor will not see them unless they have proof of having their eyes checked, because it's very important. And if caught early, a diabetic does not need to lose their vision. If not caught early, it's very common to go blind from this. And basically what happens in diabetic retinopathy is the retina itself is becoming hypoxic. You know, diabetes is a problem with circulation. You're not, you know, hence you get the peripheral neuropathy and whatnot. You're not getting proper circulation. So for some reason in the eye, the retina sends a signal that it's not getting enough oxygen. And so what it does then is the body starts growing all these aberrant blood vessels that shouldn't be there. All these little thin blood vessels should not be there. And what happens then is blood starts perfusing through these blood vessels. The blood vessels are very thin, they're very weak, and it makes the eye hemorrhage. The blood just leaks out of these blood vessels. These little yellow spots that you see on there, that's actually cholesterol that's also leaking out of the blood vessels. And what happens is if you get enough of this blood inside the eye, one, it causes traction on the retina so you can have retinal detachments. Two, when you get enough of these blood vessels in the eye, it just damages all the underlying tissue. So what we do when we treat these, what they used to do, is they used to go in with a laser and they would actually zap all these little blood vessels and seal them off. And what that would do is it would leave blind spots, because anytime you hit the eye with a laser, it scars the eye, scars the retina, and it leads to a blind spot. Now with the advent of VEGF drugs, what we do now is we inject Avastin into the eye, and it can stop the growth of these blood vessels and make them recede or disappear. Two other real common retinal vascular disorders that you may come across, retinal vein occlusions and retinal artery occlusions. A vein occlusion is, you're gonna have a person who's gonna come in with a very sudden loss of vision, and it's painless. Same with the artery occlusion. They may have a very sudden, painless loss of vision. In either case, it can be any age person. Usually retinal vein occlusions, we tend to see between the vein and the artery occlusions we usually see in a little bit more older, sicker people. Vein occlusions we can really see in anyone, because one of the common causes of vein occlusions are women on birth control pills. They can get a clot in one of their veins in the eye and they develop a vein occlusion. So usually artery occlusion we see in a little bit older population. Vein we can really see in any population. This is a picture of a vein occlusion. Basically what's happened is you have a plug in one of the veins. It causes all the blood to come out of there because of the backlog of pressure. Normally what we'll see is little, we call them splinter hemorrhages. They're little hemorrhages that look like little lines. If you see bleeding in diabetes, you'll see little dots of blood, but in a vein occlusion, you're going to see little splinter or flame-shaped hemorrhages. Cotton wool spots are these little fluffy white spots, and these are just parts of the retina that are very hypoxic or lacking of oxygen. Very common causes is high blood pressure, birth control pill, as I mentioned, lots of different things. Speaking of high blood pressure, with high blood pressure we can have a blurring of the optic nerve in the eye. So if you have somebody with really out of control high blood pressure, these people will normally come in not so much with a vision loss, but complaining that their vision is real blurry. And when you look inside, you'll just see a very, very swollen optic nerve, and again, the typical kind of flame-shaped hemorrhages. Very quickly, just to let you know, you can have problems related to medications. Plaquenil, a very common one. Tamoxifen, another real common one. Patients that are on those are usually checked by their eye doctor every single year, just to let you know that there's something out there.
If you want to let them just review trauma on their own, if you gotta go, that's fine.
Okay. Thyroid eye disease, just another one I want to throw out there. Thyroid eye disease causes swelling of the muscles of the eye. It affects soft tissues. When you get profuse swelling, because your eye is enclosed in a bony orbit, your eye has nowhere to go but out. So if you happen to see a person where their eye is propped outwards, think of Graves' disease or hyperthyroidism. And then trauma, if you would like to review on your own, probably the big ones that you'll see, this is a subconjunctival hemorrhage. It's a burst blood vessel. Sneezing can cause this, vomiting can cause this, lifting heavy furniture, not necessarily a hit in the eye. No real treatment, it's a bruise, cool compresses, stay away from aspirin. And then, yeah, the other ones, most of with these other conditions with trauma, these are going to be people that know that they've had a traumatic event to the eye and will probably seek the help of an optometrist or an ophthalmologist. And then I just put a little thing at the end of the lecture on differential diagnosis of the red eye, just kind of a little, maybe a cheat sheet to help you kind of figure out, could it be this, could it be that, to kind of help you figure out what your diagnosis will be. Thank you.
Minimize this. Minimize this. Oh, minimize it.
Did I hit the
Oh yeah, minimize.
This one?
And stop.